Good afternoon, everybody. Welcome to the Health and Wellbeing Board of the 28th of July 22. I'm the Democratic Services Officer for the meeting. I'm starting the meeting because at the moment we don't have a chair, so I'd like to request nominations from the board for a chair for this meeting, please. Thanks, Andy. I need a seconder. Thanks, Ian.
Can I nominate Councillor Webb?
Thank you.
Can I second that nomination, please?
Thank you. Are there any other nominations? As there are no other nominations for the chair, Councillor Webb, it's been agreed you're the chair for this meeting. Thank you.
Thank you, ladies and gentlemen, and I hope this situation will be sorted out finally when we deal with our terms of reference later on the agenda. Welcome to everybody. It looks like quality, not quantity this afternoon. Apologies for the meeting. I've got Councillor Poulter, who's the leader of the council. He's being topped out apparently. No, he's doing a topping out ceremony for St James's Properties on Victoria Street, so a new development in Derby City. Amjad Ashraf, Specialist Project Manager from Community Action Derby, Stephen Bateman, Chief Executive of Derbyshire Health United, Chris Clayton, Integrated Care Systems Rep, David Cox, Derbyshire Constabulary, Robin Dewis, Director of Public Health, Claire Mabani, Director of Housing Services at Derby Homes, James Moore, Derby Health Watch, Clive Stanbrook, Derbyshire Fire and Rescue, and Steve Studham, who's the Chair of Derby Health Watch. Thank you. Any other apologies? Yes.
Apologies from Councillor Lonsdale, Chair.
Thank you. Anybody else? Okay. Can I, on late items introduced by the Chair, can I welcome Jacob Savage, who's here for work experience, the gentleman at the back. He's doing a degree in politics, so I don't know why he's in a meeting like this where there's no politics involved. But welcome, Jacob, and hope you enjoy the meeting. Any declarations of interest? And we then move on to the minutes of the meeting held on the 12th of May 2022. Councillor Lynn proposes. Do we have a seconder for somebody who was present? Thank you, Pervez. Do you want me to go through the minutes page by page, or shall we agree them as printed, unless there are any issues to raise? Okay. In that case, then, we move on to item 5, which is Joined Up Care Derbyshire update, and particularly the development of Derbyshire Integrated Care System, and that's Bridget Stacey and Andy Smith doing a double act. So over to you, Bridget.
Thank you, Chair. I don't think I've ever been with Andy in a double act before, but let's see how it goes. So thank you for that. So as of the 1st of July, the Integrated Care System evolved and became in statute, and part of that saw the dissolution of the CCG and the establishment of the Integrated Care Board. The Integrated Care Board is the statutory part of the ICS, and all of the statutory responsibilities of the CCG have now transferred to the ICB. So, for example, safeguarding is a really key one, which is being addressed, as I say, by the ICB. Sorry, I should have introduced myself. I'm Bridget Stacey. I'm the Chief Nurse and Deputy Chief Exec of the ICB, here on behalf of Chris Clayton. So the ICS in totality is made up of the Integrated Care Board, the Integrated Care Partnership, which has wider partners on that, such as local authority and actually some of our anchor institutions, some of the wider socio-economic organisations. We also have provider collaboratives, which include general practice provision and place partnerships. The 4 key roles of the wider ICS is around improving outcomes in population health, tackling inequalities in outcomes, experience and access for our citizens, enhancing productivity and value for money, and help the NHS support the broader social and economic development. And as I said, that's where some of our anchor institutions come in. The board itself of the ICB is composed of 16 members, which is the chair, the chief exec, 2 partner members, one from the NHS and one from Foundation Trust, 1 partner member from Primary Medical Services, 2 partner members from the local authorities, 5 non-executive members, an executive director of finance, an executive medical director, and an executive director of nursing, and also an executive director of people and culture. So that's the composition. We had our first board meeting on the 1st of July whenever we were established, so all of the statutory requirements were fulfilled at that point. And at the end of July, we had our first public board meeting, which was streamed and members of the public can view on our website. It's very early stages at this stage, but I'm very confident because of the work that Joined Up Care Derbyshire has done as a system that we're in a very good place to take forward the ICS in totality, but also the ICB is in a really good starting point. So I'm going to hand over to Andy, who's going to talk about the ICP. Thank you.
Thanks, Bridget. And for people who don't know me, I'm Andy Smith, the Strategic Director for People Services. So I'm going to talk a little bit about what we've been doing in the Integrated Care Partnership. And as the report outlines, the ICP, and as Bridget has said, is that broad alliance of organisations across the health and care system that is very much around looking at the well-being of the population and trying to tackle some of those wider health inequalities. So we've only had a handful of meetings since the Integrated Care Partnership was established, so it's very much in its early formative stages at the moment. But just 3 things to update the Health and Wellbeing Board on. I think probably most relevant really to the Health and Wellbeing Board space is that we've been working with the ICP, looking at and trying to work through the relationships between the Health and Wellbeing Board and the Integrated Care Partnership. The overarching role and purpose of the Integrated Care Partnership and the Health and Wellbeing Board are similar, and I think we discussed that here. And the whole purpose of our being in Health and Wellbeing Boards is to lead and advise on the work to improve health and wellbeing of the local population and to reduce health inequality. So you can start to see that there's real synergy between what the ICP and what the Health and Wellbeing Board are trying to do for the populations and communities within Derby and across Derbyshire. But there's still a requirement for us to have health and wellbeing boards. That hasn't changed. We still need to have a health and wellbeing board strategy. We still need to lead on the development of a joint strategic needs assessment, but there needs to be that read across to the Integrated Care Partnership, and we need to work on making sure that we've got that connectivity so that there is a appreciation and an added value, I guess, to the way in which the ICP and the Health and Wellbeing Board work together. And I think colleagues who've been involved in recent development discussions we've had in the city around our Health and Wellbeing Board, we've agreed a much more proactive, outcome-focused approach. We're going to update our terms of reference. That's coming to the meeting today. And I think that's going to be really helpful as we kind of move further into the ICS and into the ICP. So what we've agreed in the Health Wellbeing Board space is that we're going to essentially focused on a smaller number of priorities that link to our Health Wellbeing Board strategy. And the Integrated Care Partnership is going to try and work alongside the Health and Wellbeing Boards to really kind of consider how it can add value and can consider accountabilities and to try and focus on those outcomes that we need to turn the curve on to make sure that we're connecting strategies and really looking at the way in which we can work together in the medium to long term to really try and tackle some of those perennial challenges that we've talked about here in this board. I think we recognise that it's going to be a bit of a journey, not to use a cliche, hopefully, just in terms of how we find our way forward. And, you know, we're going to have to think about the relationship between the Integrated Care Partnership, the Integrated Care Board and the Health and Wellbeing Board so that we can really agree on those areas that we need to collaborate on, but also where the roles and responsibilities sit within that kind of really broad strategic space. So it's going to be iterative. We need to get the buy-in from partners, and we're going to have to test it out as we go along. The other thing that we are going through at the moment is the due process to formally establish the Integrated Care Partnership under the joint arrangements between the Integrated Care Board, the City and the County Councils in terms of a committee structure, a committee process. That's in relatively formative stages at the moment, and there'll be a Cabinet report that will go through to both City and County Councils in the autumn just to try and place the ICP in that wider kind of governance structure and process, and we're currently working through that at the moment, which hopefully will be a good opportunity to provide some clarity and to really kind of nail down some responsibilities in a wider governance context. And then the other aspect in terms of what we've been talking about in the Integrated Care Partnership space in the last, I think we've had 3 meetings today, but certainly in the meetings today, it's been very much around, you know, terms of reference, why we're here, how it all fits together, looking at the Health and Wellbeing Board interface, as I've already said, but also then working through how we're going to develop an integrated care partnership and health inequality strategy, which is something that we're required to do under the Health and Care Act. And there are some timelines for us to do that, I think by the end of this financial year, by the end of March. So that's being led by some of the executives that sit in place, but also very much something that we're developing in the ICP space as well, just to try and ensure that this is not just a strategy that's developed in a darkened room, but actually is one that we develop and ideally co-produce as far as we can with people and with communities so that we end up with something that's going to really hopefully add value. And again, there's going to be an opportunity there, I think, Chair, to have that read across to our Health and Wellbeing Board strategy as well to make sure that we're connecting and adding value where we can. Thank you.
Thank you, Andy and Bridget. Any questions? Councillor Lind.
Thank you, Chair. Yes, I just wondered what the overall ICS budget is for this financial year and the forthcoming financial year and how that compares to comparator authorities. Thank you, Chair.
Thank you. Are you able to answer?
At this point, we do know it, but I don't have the figures to hand at the moment, but very happy, Chair, to supply those following the meeting.
Okay, thank you. As you know, Councillor Lind, we're in the process of formation of the integrated care system, and as such, we are not formally established. It's only the Integrated Care Board that has been formally established, and that's generally a clinical role with the NHS and public health and social care. The ICS is, or the Integrated Care Partnership, because there's all sorts of ICs in this, the Integrated Care Partnership is made up of a wider group including housing, community and voluntary sector, representatives from anchor organisations. So it really is a wider partnership that we are working towards, and it's good to know that the local authority is leading on this with the establishment of a relationship between health and social care. So there is work going on. Members of councils, both councils, will receive more formal briefings later in the year with regard to this, so that everybody is au fait with what's happening. But please be assured that our input as a city council is there at the forefront.
Thank you, Chair. My question was specifically to make it clear regarding allocated budget to the ICS, so I look forward to receiving those figures. Thank you, Chair.
And so do I. Thank you. Any other questions? In that case, everybody must be clear. So well done, good presentation. Thank you very much. Okay, we now move on to the COVID Outbreak Engagement Board and Health Protection Board update. Unfortunately, Wayne Harrison isn't with us today, so it's Alison Wynne who will be presenting this report. Over to you, Alison.
Thank you, Chair. Yes, unfortunately it was Robin's report who's on leave, and then unfortunately Wayne is unwell today, so I'm third hand. So but Robin has provided me with a few headlines, both from the Health Protection Board and kind of other health protection issues she wanted me to pick up. So the health, if I start with the Outbreak Engagement Board, that is currently paused. We are looking at a next meeting in September, I think it is. If it's not in, it's going in. So we'll have an update on that group next time around. But the Health Protection Board has met. That met last time in June, and a few key things to pick up from that I think. Sorry, Lindsay, if you just move on to the next slide, which picks up some of those key things there. So reviewing recovery of the national screening programmes following the disruption caused by COVID. So significant issues there, but good progress is being made within those. We are awaiting a national immunisation strategy that is due to be published imminently. But we'll see actually when that actually lands. But we've already got local working groups in place that are starting or progressing work around kind of immunisation strategy locally. We have specific discussions underway regarding improving school-age immunisations, which we do know have kind of declined kind of during the last 2 years through COVID. So we're actively looking at kind of picking up and improving on those. And kind of an outside of immunisation, there's work ongoing looking at community infection prevention and control requirements locally, and then looking at a wide range of audit programmes as well in association with that, and different models of delivery to ensure that we're putting the correct measures in place, not only in response to COVID, but I think in terms of other communicable diseases. And then finally, in relation to Health Protection Board and what's coming to the next meeting, so they've got the air quality annual report going to the next Health Protection Board meeting. So that's kind of a brief headlines from the Health Protection Board. And then if we move on to COVID, so be no surprise we have a lot less information these days in terms of COVID, both nationally and locally, but we do have the ONS survey information, which, or at least at kind of the end of the week ending 13th of July, 1 in 17 people were estimated or were testing positive at that time. Omicron is much more able to reinfect, so 5 times more likely to have reinfections with Omicron than it kind of previously with Delta, and I'm sure you're all picking up kind of on the news and elsewhere kind of that COVID is pretty prevalent at the moment, and we're kind of having some impact obviously on that. As a public health team, we're kind of been going through the data that we've had to date and lessons learned through the progress over the last 2 years and what we can take from that and learn going forward. And they're also currently updating the local outbreak management plan that will continue to be kind of primarily focused on COVID, but will be broadening its remit a little bit. And that's being worked on kind of currently. So we'll hope to be able to bring that back as well relatively shortly. Plans continue around enhanced communications and continued focusing on trying to increase vaccination uptake. We've got work underway, kind of reassessing response in relation to care home outbreaks and schools, and actively working with those settings. And also, I think you'll have again heard probably within the news over the last week or so that the vaccination programme has been announced for autumn with all over 50s, health and care workers, and those aged over 12 with long-term health conditions being offered a booster. So that'll be progressing from the autumn. And kind of final thing that Robin asked me to note is the extension in terms of previous plans to the flu programme this year. So that will include all over 50s, health and care workers, again, those with long-term illness and children up to the age of 9. And so they were the key things that Robin had asked to bring to the board chair.
Thank you, Alison. Quick question from me, and I think you'll know what it is. So herd immunity with some of the issues around children's vaccination. We were pre-COVID well up in the 90% with regard to the vaccination programme. Have we dropped considerably, and is there a risk?
Yeah, I haven't got the figures to hand, Chair, but there definitely has been a decline, and I think it's across all the children's immunisation programmes. And actually, I know we did used to, I think regularly as part of this item, bring updates in terms of immunisation uptake, and we haven't done that for a while, so make sure that that's on the agenda in kind of one of our coming meetings. Then we can also give an overview of not only where we're at, but also the actions that are taking place to promote and improve that vaccination uptake.
Thanks, Alison. Any other questions? Yes, Ian.
Hi, Alison. I appreciate this isn't your area. You mentioned the national immunisation strategy should be launched at some point. We don't quite know when yet. Do we anticipate that that's going to be anything different to the current sort of strategy? And you was mentioning the current rollout to the over 50s and health and care workers and children over 12. Do we think it's going to shake things up and have a different approach, or will it really be ratifying more of the same?
I think it's one I'll take away and check out with Robin, but I guess it wouldn't be, I think probably shake-ups probably a little strong, but I'd imagine that there'll be probably some tweaks and changes around the edges, but I'll take that one away to Robin and others and come back to you, Ian.
Okay, thank you. Anybody else? Yes, Councillor Lind.
Thank you. I was just wondering, will they be the same vaccines that we've previously had, or will there be new ones?
In relation to COVID, so I think the current booster programme will be the existing vaccinations, but again, it's not my area of expertise, but I think that there's ongoing work around the vaccination programme and kind of other ones in progress. But where we are at the moment is, I see Magnus waving. Thank you, Magnus.
Sorry, Magnus, could you say that again? Your mic wasn't on. If you just press... Ah, right. Okay. Okay, we'll get one sorted out. If
Thank you. So, just for clarity, Magnus Harrison, I'm the interim CEO at UHDB. I'm the executive medical director substantively. I led medically on the vaccine programme that we rolled out at UHDB. So there aren't any new vaccines. The vaccines that we had earlier this year and last year, it's exactly the same set of vaccines. The work that has been done is if you mix the vaccines, do you get more of a response and more safety and efficacy as a consequence of that? We don't know the answer to that yet. And then the tiered response that we had around who was most at risk, I suspect will be followed nationally again. But the timing's critical, and the timing's critical because you don't want the antibodies to dip down as winter arrives, but similarly you want enough chance to develop antibodies prior to winter arriving. So I suspect there'll be quite a thrust to do it quite quickly for the at-risk populations. But as Alison said, we'll be waiting national guidance. Don't hold your breath.
Is there any evidence about how long you use your mind? Is there any evidence, Magnus, about how long the vaccination protects people?
Yes.
So what is that duration?
I knew you were going to ask me that. It depends which vaccine you've had. So for each of the different ones, whether it's Pfizer, Moderna, or the other ones that are available, there's studies that look at how quickly the antibodies drop off. I couldn't quote you those figures. I'm sure if Robin were here, she'd just roll them out. Yeah. So there is evidence out there, definitely.
I'll take that and come back on that.
okay, thank you, Magnus. Any further questions? In that case, then we'll move on, and it's Alison starring again. She's turning the curve this time.
Thank you, Chair, and Andy nicely, and Bridget and Andy nicely lined this up earlier. So thank you very much for that. I know. I'm not going to take you through the slides in detail because I'm not sure that they work necessarily well on the big screen, and you've all had the information in your packs. But I'll take you through some of the key headlines of it. So just got distracted with perverse dismantling equipment. Just move on to the next slide for me, Linz. So just as way of background, as Andy mentioned earlier, we obviously had a number of development sessions with the Health and Wellbeing Board last year, working out kind of its role and responsibility and what it wanted to focus on. And obviously a kind of clear remit of the board is to improve population health outcomes and reduce health inequalities. And building on work that was already started under Joined Up Care Derbyshire on this, trying to look at a kind of population health outcomes focused way of looking at things. So we were kind of building on that and looking at really if we wanted to make a change in kind of those health outcomes and change health inequalities, we're really, I guess, starting to look at things like life expectancy, healthy life expectancy, and the inequalities gap between those is really what we're looking to shift. And if I take you if you go on to the next slide. So we ended up with kind of 7 outcome indicators or things that we wanted to shift. But the diagram there it's on the right on my screen, so I presume it's on the left on your screen, just gives an indication of the drivers. So what are the things that are driving kind of premature mortality and kind of the inequalities within those? And we're looking at causes of death that, there are others, but the biggest drivers of those are cancer, respiratory illness and circulatory disease. And then if we move back a step further and look at actually what are some of the key drivers of those, then we're looking at things like smoking, alcohol use, healthy weight. I think one thing I did want to say, I think within Joined Up Care Derbyshire we'd agreed, I think 5 of those outcome indicators, and as a health and wellbeing board and as part of those development sessions, I think the board was really clear it wanted to also include housing standards and kind of housing as a key outcome indicator, but also something around kind of mental and emotional well-being. So we're still exploring kind of some of the indicators and the things that we'll focus on with those, but I guess that's how we came to the 7 kind of areas that we did end up coming to. So as we said earlier, I think we've got a clear focus on these issues now, but I think what we haven't done necessarily as a board and didn't, I think, significantly as part of the development sessions, really understand where we are on some of those. So I thought perhaps just giving the board kind of some of the headlines in where we are on these things. Not saying, so I'm not going to go into what we're currently doing. I think we can do that in other sessions, but just to, I guess, set the scene in terms of where we are and kind of where we're working from. So just starting with life expectancy, and you'll see Derby is unfortunately the green line at the bottom, and I think actually nationally and regionally we're starting to see kind of life expectancy after a long period of increase in life expectancy, that's starting to track downwards. But you'll see for Derby and for both males and females in the city, that's sort of tracking down or kind of deteriorating quicker and further within Derby. In terms of inequalities in life expectancy, so this just gives you an indication across males and females, kind of the difference in life expectancy. If you're looking at kind of the one of those kind of most deprived areas to number 10, which is kind of the least deprived areas within our city. And you'll see, I think it's an 11-year gap in life expectancy for women and 10 for males. And then if we start to bring in things like healthy life expectancy, so these are the years that we can expect to live in good health. Actually, you're knocking probably another 20 years off there or thereabouts for men and women in the city. So, and these are the I guess the average for the population as a whole. If we start to look at kind of as per the previous slide, if we're looking at the difference between kind of the most and least deprived, those grey bands will be, or both of them will be kind of tracking back a lot earlier. So we're looking at, you know, in some of our most deprived neighbourhoods that actually people can be living with kind of multiple long-term conditions from kind of 40s, mid-40s onwards. So we're looking at, you know, actually fairly early years and kind of long periods in relatively poor health. So some of the things that are driving that, so looking at under 75 mortality, so premature mortality, so from all causes. You'll see again that the green line, that's tracking up, so we're seeing increases in under 75 mortality rate in the city, and that's again higher and moving up quicker than the region or the kind of national averages. The bars on the other side of the page that are all red, they are our what you describe as our nearest neighbours. So they're the local authorities that are considered to be most like Derby, and you'll see that they're all red in that they're significant worse than the national average, and you'll see kind of Derby's in kind of the middle of the pack there. Premature mortality in relation to respiratory diseases is up and down, and is currently actually tracking down, and Derby, you'll see, is at the lower end of our comparators there, although still significantly higher than the England average. Cardiovascular disease, again, this is one that is tracking in the wrong direction, so again heading up, and Derby again in the middle of the pack with our nearest neighbours. Cancer, similar story, heading upwards, and this is against kind of what appears to be kind of declining rates in kind of England as a whole, but again in terms of our nearest neighbours, kind of say middle of the pack, it's middle of not a great pack. It's not good news really. And then just picking out kind of premature mortality for those adults that have got a severe mental illness. So premature mortality much more frequently, or much more frequent within those that have a severe mental illness, and you'll see that the direction of travel is quite notably upwards with that group of individuals. This slide gives an indication of those causes of death, the causes of death that are contributing to the gap, inequalities, if that makes sense. And in previous years when I've looked at this, obviously COVID wasn't there, but is kind of a new addition. So we're seeing that those gaps in life expectancy in terms of inequalities are being driven primarily. We've got COVID, circulatory disease, so that includes things like heart disease and strokes, cancer and respiratory disease are some of those biggest drivers of those health inequalities and kind of gaps in life expectancy. So I guess that gives the background on some of the things that we're really looking to change. And now if I move on to the things that we're planning as a Health and Wellbeing Board to focus on to try and make a positive impact on some of those things that I've just talked about. So if we just start with smoking prevalence, and actually over the last few years we have seen a reduction in smoking prevalence over the last few years. So 2 or 3 years ago we were at about 19%, and we're down now to 16.7%, but still a reasonable chunk of our kind of adult population. But if we look at kind of those adults within the city that are working in routine or manual occupations, we're actually looking at just over 35% of that population smoking. And also if I kind of pick up those with severe mental illness, so the group that we've just been talking about in terms of life or premature mortality, just under 40% of that population are smokers. And we've got just under 20% of women that are smoking in early pregnancy. That goes down a bit in terms of actually smoking at time of delivery, but just gives an overview of kind of the level of smoking within the city and how it varies between different populations and cohorts within the city. In terms of healthy weight, so the top graph there are our reception year children. So these are kind of children first year of schooling. You can see certainly the picture, the line for Derby is pretty up and down and is currently on a down. I think where the main concern is the graph below, and these are our year 6 children, so at the end of primary school, so just before they go into secondary school. So we're looking at children aged, I think about 10 or 11, I think is the the age. You'll see that that green line there has been, you know, consistently higher kind of than the national figures for some time, and is tracking upwards at a, you know, higher rate. And I think Robin at a previous meeting had, I think, mentioned, I think some of the work and analysis that we've done over COVID is suggesting that within that group there's changes as well. So we're seeing a kind of high proportion of those, that's is overweight and obese, that we're actually getting kind of a higher proportion that in the obese and in the severely obese category. And in terms of adults, kind of last figures, again, also increasing, and that we're looking around 65% of the adult population being overweight or obese within the city. There's a slide there on alcohol consumption, but I know Richard's got, I think, a few figures in relation to that, so I'll let Richard, who's kind of the expert in that, cover that one. So in relation to physical activity, so we're actually, just below. This one's not a good one to be below, actually. So in terms of physically active adults, I think we've got, I think it's just over a quarter of adults that are not undertaking kind of the recommended levels of physical activity within the city. And children living in low-income households, and this feels, I think, particularly pertinent. I was on a Poverty Commission call with Paul and others this morning, and you know, and where we are currently doesn't look great, but I think the direction of travel is likely not to be a good one. So we have just under a quarter of our children living in what we describe as relative low-income families, and 20% just about in absolute low income. So we've got a big chunk of kind of our children living in low income families, and that that will vary quite considerably depending kind of where you are within the city. And then finally, in terms of housing quality, and again there's quite a bit more information that we'd like to bring to the board probably at one of our future meetings, but in terms of headlines, in terms of private sector homes within the city, we're looking at just over a fifth, so I think it's 21.4% of that sector don't meet the decent home standard, and just over 14% have got a category 1 hazard, and a category 1 hazard is one of those, is a hazard that has an immediate risk to health of the individual there. And I, again, was in a meeting, I can't remember if it's this week or last week, Ian, but we're kind of reporting kind of how, again, similarly, how that varies quite significant between housing stock in different parts of the city. So the 14% is an average, but it does go up significantly within areas of the city. And then finally, kind of mental and emotional well-being. So as I said, we're looking at actually what potentially the best indicators for these. But just to give you kind of an idea of, I guess, some information. So looked at depression and recorded prevalence, and you'll see kind of over a number of years, kind of both nationally and locally, we're seeing increases in the prevalence of depression, and the gap looks to be kind of growing slightly between kind of the England average and Derby. And then self-reported well-being, so people with kind of high anxiety score, and again that's just over a fifth, so 21.5% of kind of people within the city are kind of describing themselves or that having kind of high anxiety. So that's, I think, just a quick rattle through, and obviously I've not talked about kind of any of the activity that's ongoing within those areas today, but I think was just to give you a sense of the scope of the challenge. And a lot of the figures that we're reporting today, they're the most up-to-date figures that we have, but with the reporting gaps, we know that actually probably given the impact of COVID and other issues like cost of living currently, that actually they're probably kind of worse than we're reporting today, and it's kind of an added challenge to us. And the proposal is that we kind of set through upcoming board meetings to focus on perhaps one or two of these each health and wellbeing board, to dig under the information, but give a bit more of a rounded picture, but also, I guess, start to understand and get some assurance in terms of actually what are we doing about it within the city in terms of tackling some of these things. So I think that's where I want to finish, Chair.
Thank you, Alison. Lots of detail in there, lots of information that would suggest that there are activities that people could take up to actually reduce health inequalities. So give up smoking, give up drinking in excess, definitely give up drugs, and you know, obesity is something that is going to be and continues to be a challenge. There are, as I say, things that we are actively doing to meet some of those challenges, but it does need people to come on board with that. We offer Live Well services which meet those 4 challenges. It's a universal offer and people can self-refer to that. So there are actions that we are taking, but if the curve keeps on rising, then there's got to be other ways that we can think of dealing with it, and that is something for a future health and wellbeing board. The housing issues, I know that we're looking here at private rented sector and private housing. Social housing doesn't feature on this, and as I understand it, ALMO, Arm's Length Management Organisation that looks after council housing, met the standard in 2004, was it? 5. So we're coming up to an anniversary of 20 years of decent homes in the council housing sector, and so there'll be some refurbishment work ongoing in those houses to bring them up to date from 20 years ago. But those are activities we are currently doing, and it's just to show that we're not avoiding the questions that have been raised in this report. Are there any other questions? Yes.
Yeah, thank you, Chair. I mean, it's a really depressing report, isn't it? I mean, I was quite shocked, actually, to be fair, even though you'd be, I suppose, pretty obvious things aren't going to be great, but this was quite remarkable to see that almost every single metric is really bad, and Derby is behind the national average on just about everything. But obviously all these areas to improve, they're all obviously admirable, and I was just a bit surprised. What can we be doing? What can we actually do locally as a health and wellbeing board to change the number of children living in low-income households? And that was without the government sort of really being involved. That was the question.
Yeah, and to be honest, I think that's a real challenge probably across quite a few of them. So, you know, national policy obviously is implicated in almost all of those. And I think, actually, one thing I didn't say at the beginning, which I think is really important, one of the reasons I think we wanted to focus on these things as a health and wellbeing board, but also Joined Up Care Derbyshire, I think more broadly, is a recognition that actually it's a whole range of different things and efforts that combined hopefully starts to make a difference on these, and it's recognised which are the things that we can, and the actions that we can do locally, either as individual organisations or partners and collectively, but also potentially where are the things that we can come together and also potentially looking at kind of that lobbying, or where are the things that we need to look at taking things into that wider agenda too. But I think it's breaking down into what can we do and where is the activity being kind of led and managed, and making sure that we're doing kind of a system-wide approach. So actually if we're all doing a little bit, or kind of what is within our gift, either as individually or collectively, that actually when we start to add those together, we start to see a different, but absolutely recognise that not all of those things are within our gift, but I think being clear about what are, and making sure that we are taking action on those as far as we can, and taking some of those things that sit kind of above and beyond, but we take those actions and shout about that as much as we can.
Thanks, Alison. Yes.
Hi, I'm hoping that this is a helpful comment, just feeding into the point about children living in poverty. So Jane Needham, I work for Derbyshire Community Health Services. So we've just had some very recent discussions with Derbyshire Healthcare Foundation Trust to deliver the health visiting and school nursing services for Derby City. So within Derbyshire, we've been able to separate some funding, some non-recurrent funding, to put into citizens' advice services in our health visiting service. We've invested a small amount of money, 120k, which has then resulted in fast track for citizens' advice for the families in Derbyshire, and it's identified £1 million worth of unclaimed benefit income, sorting out debt that's available. So 120k gave £1 million return. We've drawn down some personalisation agenda money, small amount that we've worked with Derbyshire Healthcare, and have asked if Derbyshire Healthcare could set up something similar within Derby City. So that hopefully is something that's in train through the healthcare providers there, which will start to directly get money into the families' pockets through citizens' advice services. So hopefully that's helpful.
Thank you for that. Any more?
Thank you, Chair. I was just wondering, is there any local modelling specifically that would suggest what impact that the cost of living crisis would have here in Derby on life expectancy, healthy life expectancy and inequalities? And if there isn't, can we do some modelling to ensure that we have a plan to address the different scenarios that may become before us in coming months? Part of that plan, for instance, could be to ensure that we've got debt clinics across the city that people can access. I think that we really should be thinking about what we can be doing now in preparation. Thank you.
Go on, Alison.
I think yes and no. So I think there's kind of a small amount of work that has been done, but actually we were talking, I think just this morning, weren't we, Paul, around the need to do kind of a significant piece of work around this to actually understand it in more detail and what that impact is going to be likely to be. So absolutely agree. There's, like I say, there's a little bit that has been in train, but there's definitely more that we need to do to, we will never have a full and perfect picture, but we'll be able to get, I think, to a better place in terms of trying to understand, well, what is it potentially going to look like for us, and what does that mean? And like I say, I think Paul looks like he's ready to go.
Yeah, I think on that point, I think there's short-term work and there's long-term work. The reality is our short-term work is to make sure people survive the winter, because it's that challenging. And so I've kind of crudely worked out we need an additional £250,000 to do things like community meals, to do more debt advice, to ensure that we provide, and when I say food, I don't mean food parcels, but stuff that supports people, and other stuff alongside that. But I think it very much is, we've got to be in survival mode in the short term, because it's ever changing. If you look at the Sky News report this morning about the increase of utility bills that are coming in October, and now it's going to be every 3 months, so it's coming in January as well. It's very high. Within that, and one of the things we raised this morning is also something around people living in social housing and prepaid meters and pay more money and don't have a choice in that, and we've got to be looking at something, and it's something we're looking at initiative-wise on that. But my other kind of 2 things that I wanted to throw in, that one, all these points naturally are very much health related, and they should be. I think the thing that we also need to throw in there, and I know some people say this is a bit of a wish-washy thing, but actually what is related to all of this is actually about people's happiness. If people are more feeling happy in terms of life and different things that way, then you feel more mental health wise and whatever in a place to maybe address certain things. And I think we've got to look at the correlation of kind of that side of it. And I know there's international studies and European studies that show the UK is pretty low. I don't know how they worked out the studies, but they've done certain things. And the other thing around the whole obesity thing, which kind of always makes me laugh about Derby, and it'd be interesting to kind of know in terms of other cities if we have a higher proportion of takeaways in our city than most cities. I live in Alveston, and we've got 18 in the space of a quarter of a mile, and I think we quite often we tell people what they should do, but actually then we dangle the carrot in front of them, and they always get signed off more and more takeaways open in the city, and I think sometimes we actually need to look at what we're doing that actually discourages people from tackling stuff rather than encouraging. And I think it's an important thing for us to look at in terms of the healthy offers that at the end of the day, people have choices and people can make choices, but you look at it, there is a high proportion of things like the takeaways and other stuff in the city, and we need to look at that ourselves, what we're doing about it. And then my final thing around the private housing is that I think we need to stop being afraid as a city to look at trying to bring in a kite mark around our private housing and stop, which has been looked at for quite a while, but has been discouraged in certain arenas, I think for some very personal reasons why people have discouraged it. And I think we need to recognise, if we actually want to truly raise the standards, then we need to actually say this is our expectation and encourage people to try and meet it. We can't force them, and not play some of the the politics that we've played over the years around that issue, I think. Thank you.
Thanks, Paul. On your last point about private rented sector housing, we are working with the private rented sector, and we are looking at a licensing process which hopefully will come before council before the end of the year, to increase the quality of housing in the private rented sector. You're aware of the ability of private landlords to serve a Section 21 notice, which is a no-fault eviction order on tenants, and that's been tended to be used for tenants that complain about the quality of the housing that they are renting. So yes, we are aware of issues like that. You've made some really good points there, Paul, and we are looking at a lot of them, but you continue to keep prodding and keep doing that work. Takeaways and planning permission is a can of worms that we would like to open, but nationally the planning inspectorate only go on the item requiring planning permission, not the number of premises that are within an area. But we could look at a saturation point whereby, and I think it's been done in a couple of areas in Derby, whereby you reach a point where there are so many takeaways and you say no more after that, and that becomes a planning condition. So there are ways that we are looking at, but no, keep prodding.
Yeah, it's just on your last points, Paul. I think actually that was a good one in terms of just the. I think it's us all asking the question of actually what can we do? What are the decisions that we are making that either making it easier or more difficult for people to make healthy choices. Obviously, all the things I've just gone through today are all absolutely interrelated with one another, but also absolutely related to kind of a whole range of wider determinants, you know, drive happiness and happiness drives it. So they are complex issues, but I think is absolutely why we need to be considering them in the round and tackling them in the round. So yeah, it's absolutely, I think, part of the direction of travel I think that we want to progress. So thank you.
Councillor Lind. Sorry. Councillor Lind.
Thank you, Chair. Thank you, Paul, for a comprehensive response. It's much appreciated. Paul mentioned potential need for an extra £500,000 in funding. So I'd just like to ask what extra funding has been allocated to address the cost of living crisis here in Derby, and what is the projected funding moving forward? Thank you.
I don't know, Councillor Lind. I'm not sure if anybody kind of in the meeting knows.
I wouldn't know directly. We'll get you an answer to that. But there are activities that are going on with the boards that have been set up. Paul runs Food for Thought, and there are health improvement board, so there are activities related to that, and all those come at a cost. So there is some investment in it, but actual figures we'll have to get back to you.
We bring that to the next board, Chair.
We'll ask for it to be put on the agenda, yes. Okay, if that's it, we move on to item 8, which is the drug strategy update. So that's over to you, Richard.
Thank you, Chair. For those who don't know me, I'm Richard Martin. I'm an Assistant Director of Public Health, and part of my responsibility is the commissioning of substance misuse services and the development of drug strategy and alcohol strategy. I have a presentation that supports the item that you have in the agenda, item 8, which is titled Drug Strategy Update. But do I just say next slide, Lindsay? Or can I remotely? No, I can't remotely control it, sorry. I thought it would be useful to present a two-part presentation. Part 1 speaks very much to what Alison has described, in that it focuses on the role that alcohol plays in relation to mortality and morbidity. It also speaks to the objectives that have been agreed by Joint Up Care Derbyshire and the Health and Wellbeing Board. And by way of making it more practical, it outlines a plan which we had developed in 2021 in order to address some of the statistics that I'm going to share with you. Part 2 is conjoined in the fact that in December last year, the government released a drug strategy from harm to hope, and in that drug strategy, it makes no apologies that that strategy also addresses alcohol harm, even though it's called a drug strategy. And the plan that we developed here in the city dovetails and has been consumed by that submission to local government. So that's why it's colour-coded, and that there's going to be two parts. I will make two apologies. One is to Bridget, that you're going to be subjected to this repeatedly because I'm going to say the same thing to the System Quality Group. And secondly, some of the statistics that I shall share with you are sobering, and there's no pun there because I'm talking about alcohol, but they're arguably worse than some of the things that Alison had projected. So, next slide, please. Sorry. In regard to healthy life expectancy and life expectancy, it's no surprise that those are improved if we reduce harmful alcohol consumption. And as I indicated, reducing harmful alcohol consumption is a priority for the system strategically. Next slide, please. These are some very elaborate charts that I make no claim that I produced them. They're produced by Alison and her colleagues. And what they, if you can see, what they attempt to do is they take one of the three main causes of mortality that Alison alluded to, this one specifically, cancer, illness and death caused by cancer, and I've tried to, with very clumsy large arrows, to point out that alcohol plays a significant contributing part to a number of cancers. I'm not going to list them, but it's so significant that the evidence would suggest that reducing harmful alcohol consumption, or generically reducing alcohol consumption, lowers your risk of mortality from cancer. Next slide. Again, a similar type of approach. This slide indicates that you can reduce illness and death from behavioural and mental disorders by reducing harmful alcohol use. And next slide, please. And finally, you can reduce musculoskeletal disorders by reducing alcohol consumption. And I'm not expecting you to remember this, but if you go back to the slides that Alison, one of Alison's first slides, it was like a bar chart or a series of bar charts, and it demonstrated that those three things, reducing musculoskeletal disorders, cancer, and this cardiovascular disease, that they are some of the most significant impacts on Derby City in relation to healthy life expectancy and life expectancy. So what I'm trying to demonstrate here is that by developing sophisticated approaches to tackling the harms caused by alcohol locally, we can have a significant impact on healthy life expectancy and life expectancy. Next slide, please. This is where it becomes slightly sobering. We've done a series of analyses, and it's safe to say that the position in Derby, i.e. the harms caused by alcohol in Derby, are particularly significant and worse than the England average. I'm not going to sit here and read these, and like Alison suggested, I shall take choice snippets from the data, but you can see here that we are significantly worse in relation to admissions to hospital for alcohol-related cardiovascular disease, alcoholic liver disease, and mental behavioural disturbances caused by alcohol, and that men are disproportionately affected, more so than women. Sadly, the bottom point points out that there were 22 alcohol-specific deaths. 9 of those people were in treatment, and that doesn't sound a lot, but in reality, we are contributing 1% to the national profile of alcohol-related deaths. So we are a significant contributor if you consider the population of England. Next slide, please. Chronic liver disease in Derby seems to be particularly worrying. Since 2001, Derby has seen a 63% increase in death from alcoholic liver disease. Admittedly, the numbers are small, whereas the England average has been 43%, and the average age of somebody dying from alcoholic liver disease is 58 years old. There are some ironies here. A survey done by our colleagues said that in 2008 there was 24.4% of adults in Derby who claimed to abstain from drinking or were drinking only moderately. Admittedly, that's underreporting, and that is remarkably lower than some of the national English data. So you have to question that. So in theory, in English, people in Derby claim to drink less than the rest of England, but seem to have significantly worse health outcomes. And we used Experian and Acorn data to analyse purchases in supermarkets and on the internet And in 1 week, there was nearly £850,000 spent on alcohol, and that excludes pubs and clubs, and that's in Derby City. So it's unsurprising that there are the health consequences that we're alluding to. Work done by Sheffield University estimates that there are 3,177 alcohol-dependent individuals in Derby City who require treatment, and we have a 77% unmet need. So in reality, there are 618 people in structured treatment. So a very, very low penetration rate and a low unmet need. Hence, the reason we developed a plan to address some of these, and also the government recognised over a period of time when Dame Carol Black did a review that there is a massive health inequality in relation to those that consume alcohol problematically. And as a result, the strategy was released in December. So just to summarise, we recognised by analysing data that something needed to be done. There was a plan developed, and fortuitously that was developed against the backdrop of NHS England investment in hospitals, and Royal Derby was one of those hospitals, to augment or optimise the alcohol care team. What an alcohol care team does, it identifies individuals in hospital who are there and unlikely to be there due to problematic alcohol use, and then it deals with them in an appropriate and sensitive manner, likely to instigate treatment whilst in hospital that's continued in the community. Again, you don't need me to tell anymore. This segues quite nicely into the strategy that's been launched. So what we have now, moving forward, next slide please, are a series of objectives, and these objectives are reflected in the strategy that we've got for the city, which is a combined drug and alcohol strategy. Without going into a great amount of detail, we are seeking to improve the treatment pathway between the hospital, because as you've seen, a lot of that data is hospital-oriented and hospital-generated. So improve the pathway between the hospital and community treatment, so that we're picking up more people for issues in hospital, because there's a gap between them leaving hospital and reaching the community, and there is a hell of an attrition between those two locations. We're looking to identify liver health problems earlier, working with our own systems for mobile fibre scanning, working with primary care, and developing some of the work that we've done at the Florence Nightingale Community Hospital and the Prevention Hub, working with LiveWell. So a lot of taking treatment to the people as opposed to expect them to approach a specific point. And again, working very strongly and reigniting our work with the hepatology and gastroenterology departments at the hospital. Next slide, please. It wouldn't be public health if we weren't looking for earlier engagement and prevention. And again, here is a list. I'll need to read that at your leisure, but we are proactively seeking to improve a number of interventions, and that is there may only be 3,177 individuals who are deemed problematic and dependent drinkers, but there are 30,000 binge drinkers. There are 5,000 individuals who drink at increasing risk. So it's about, what about those? What are we going to do for those people? So we're looking for digital solutions, social marketing solutions, and prevention solutions in order to engage those to prevent them from becoming problematic alcohol users. Next slide, please. I think that's just capitalized. That's just outlined here. We need to be smarter, more responsive, insight-driven, intelligence-driven, working with Alison and our providers to, as I say, take treatment to people, because there's quite a difference between drug treatment and alcohol treatment. There are no quick wins with alcohol treatment. There are limited tools available, and I think speaking to some of the other points, as we'll talk about when we speak about the drug strategy, there are many hidden reasons why people consume alcohol problematically, ranging from genetic to various models of addiction to coping with trauma, undiagnosed mental illness. So it's not as straightforward as people assume when we try to deal with alcohol treatment, and it's not, ironically, as straightforward as dealing with substance misuse or drug treatment, because we don't have sympathetic or substitute prescribing. Next slide. Okay. Now we'll talk about drugs, and as I say, there's a lot of emphasis recently on drugs. Next slide, please. Thank you. Dame Carol Black conducted an independent review over the last 2 years, and what a review identified was that over the last 8 years there's been significant disinvestment in drug treatment and methods to address drug harm. Simultaneously, there's been an increase in drug-related deaths and drug-related crime. So what Carol Black has done is she's informed government, and governments have decided to develop a drug strategy. And for the first time in a long time, that strategy comes with fairly significant funding. The 3 strands to the strategy: breaking drug supply. That is primarily the preserve of the police, delivering world-class treatment, which is the preserve of local authorities, public health, and those who commission treatment, and the NHS. And achieving a generational shift from the demand in drugs is an all-encompassing catchphrase, and that phrase is to address attitudes to drugs in schools, in school settings, but also in the general population. And very recently, there's another piece of guidance published, I'm not going to go into that, about a new tiered system for those who choose to consume drugs and are caught in possession of drugs, ranging up to taking people's passports and driving licenses away from them if they have 3 occasions where they're taking drugs. Next slide, please. The drug strategy is very ambitious. It seeks to prevent nationally 1,000 deaths, to increase drug treatment places by 54,500, and to reduce 750,000 drug-related crimes. Different to alcohol, the lens that the government view drugs is that drugs are a leading cause of acquisitive crime and violence, ranging from county lines, gangs, and importation of controlled drugs, right down to people using drugs or people committing crime in order to fund their drug habit. So there's a lot of emphasis on the connectivity between policing, the Home Office, and this new drug strategy. Our efforts as a local authority and as public health commissioners is primarily to act as a system integrator, but also to commission world-class treatment. Next slide, please. Of note is that the strategy comes with a very heavy and significant governance and accountability requirement. We are expected to establish a local combating drugs partnership, which will be a county-wide footprint. There is a requirement to appoint a senior responsible owner who is accountable to central government. And I like to define it as the good and the great will sit on that combating drugs partnership and oversee all elements of the drugs strategy, including the efficacy of treatment and including the efficacy of the police in reducing drug-related offences. I'll be speaking, hopefully, with Andy and Bridget, if possible, after this meeting in order to secure some support for both the nomination of a senior responsible officer and the representation of the Combating Drugs Partnership. Next slide, please. This slide simply outlines what the government expect. It's the National Combating Drugs Outcome Framework, and as I've alluded to, their ambition is to reduce drug use, reduce drug-related crime, and to reduce the number of people dying from consuming drugs. And they'll measure that by the number of policing operations and disruptions of major criminal networks, increasing the numbers of people in treatment. Continuity of care is particularly important. Continuity of care in this sense relates to individuals leaving prison and secure estates and entering the community, where they have an opportunity to enter into treatment. And it's a concept which is quite American, but it's reflected also in mental health. The concept of recovery is, how do I describe it? Individuals recover from their substance misuse by addressing the wider determinants of their health, their housing, their relationships, their criminality, their substance misuse. And in combination, those elements form a recovered status. So bizarrely, we're measured on recovery, not just how many people are in treatment and whether they exit treatment drug-free. It's how recovered are they? How integrated into the community are they? How stable is their accommodation? How is their employability? And that, as we've alluded to with poverty, there are many factors that make that concept of recovery quite complex and quite difficult to measure. But I'm confident that this national combating drugs outcome framework will be distilled at a local level with a very sophisticated framework that will be able to demonstrate the efficacy of the investment. Moving on, again, maybe some kind of grim statistics here. We're seen as an area that needs enhancement by the government, and we have been awarded a supplemental substance misuse treatment and recovery grant. Sorry, I'm saying that when you've had a drink. That grant complements the current investment that the Public Health Ring Fence grant spends on substance misuse. So we're quite confident that they have recognised that we've got a problem in Derby City. Not so much more than other areas of a similar size, but we've been awarded a Section 31 grant to add to our current investment. That's because there are approximately 2,094 individuals who are currently in structured drug treatment. I think there's an estimate that there's 2,162 problematic drug users who use crack and opiates. And that represents that we're only penetrating 50% of the drug users, so there's 50% unmet need. So what this new investment is aimed at is improving the quality of treatment, improving the capacity of treatment, and allowing us to penetrate hitherto unseen cohorts of individuals, such that we can gauge them in treatment and, again, meet the government's objectives of reducing crime and reducing drug-related death. Sadly, again, in 2021, there was 22 drug-specific deaths, and again, that contributes 1% to the national total of drug-specific deaths. So we're quite high up there. Next slide, please. This is where it becomes a bit too technical, and what I'd like to do is to be able to circulate this presentation, because I don't propose to go through all of the slides. But the next few slides outline a 3-year strategy for Derby City that has been defined by our submission for the Supplemental Substance Misuse Treatment and Recovery Grant, this central government grant. And that submission actually is written in a way that's quite prescriptive. We've been given a menu of options. It's not that we can randomly choose what we spend money on. We're given a menu of evidence-based options. And I think what we are looking to do, some of the key headlines, is work in partnership with the county where we can, in order to address joint issues where the footprint and the economies of scope and scale make sense. We're obviously looking to prevent young people from becoming adult drug users moving forward. So there's quite an investment in relation to public health, nursing, and Tier 2 and Tier 3 substance misuse interventions for young people. We're trying to make our treatment system world-class in relation to therapeutic relationships with our clients. Next slide, please. We've got a bespoke plan to proactively reduce drug and alcohol-related deaths by using interventions such as naloxone and Narcan, and these are materials that can be given to drug users and drug users' families that reverse overdose if taken at the point of overdose. As I say, it would become like me reading out a shopping list if I just sit here and read these things out. So I think the key highlights are, let's go down to some of our targets. As we seek to contribute to the government's ambition of a 20% increase in treatment places, we've set our own targets, and that is that we're going to increase the number of individuals in alcohol treatment by 100% over 3 years, taking that up to 1,386, which is a reasonable penetration rate to the number of problematic drinkers that we see. We're going to increase the number of young people in specialist drug treatment by 150% over 3 years. I mean, the numbers are small, so that's not overly ambitious. We're going to increase the number of opiate and crack users in treatment over 3 years by 10%, and similarly, those who are drug users that don't use opiates, a similar target of 10% increase over the next 3 years. Next slide. This is very fine detail, but this is our narrative or discourse plan for the reduction of deaths, and we're aiming to reduce or have 7 fewer deaths from drugs and 7 fewer deaths from alcohol over the lifetime of this strategy, which, as you can see, we're only talking about 20 and 22, but any death from drug and alcohol is a death too many when it's avoidable. Next slide, please. Spoke of continuity of care. I would be remiss if I didn't say that the government are very keen that everybody who is an offender with an addiction leaves prison and has a place in treatment, and that our set target, a local aspirational target, is that in relation to the continuity of care, 75% of people who leave prison with a drug requirement enter into treatment to the local system, which is fairly ambitious. And again, there's other elements that have been prescribed within the allocations, that we increase the utilisation of residential rehabilitation. A lot of people think about Amy Winehouse and inpatient detox. They're very expensive interventions. People normally go into rehab for 6 or so months, but it has a very good outcome, even though it's intensive and expensive. Next slide, please. Sorry, I'm ahead. There were two more slides there, sorry. Yeah, I've just gone through those figures. Yeah, I think we've already talked about a desire to prevent young people becoming adult drug users of tomorrow and transitioning. So I think there's an outline there about developing strong connectivity between young persons, public health, school nursing services, and specialist substance misuse services for young people, and 16 to 25 proactive outreach. So I think that is the last slide. Okay, apologies, it was fairly whistle-stop. There's a lot of information there. None of that information is in any way secret. This is a strategy that's available for all to see. The figures that are quoted in there are figures that have been confirmed by government through their .gov website, and we were asked to speak about that on Radio Derby, so there's nothing that's in any way sensitive within there.
Thank you, Richard. Extremely informative, and it's nice to know that you've got a plan. I've always been proud of Derby being the real ale capital of the country, and our 2 beer festivals, summer and winter beer festivals, I always attend. I'm obviously going to have to cut down, so probably take out 1 beer festival rather than do both. It's eye-watering, the figures in there. I don't know what we're doing with regard to people that are in housing that have these sort of problems, so alcohol and including drugs. And one of the comments that you get from residents when they're complaining about drugs or alcohol use in premises is that there's no response to it. And I'm wondering where that sits in your strategy, because if we know where it's happening, then we should be in there to help and support, not necessarily, shut them down, but to help and support. And the other issue that relates to housing is the cuckooing and county lines. So I'm wondering what you can do with those.
Excellent. People will think that I've paid you to ask those questions, and I haven't. Our approach is to use intelligence and insight and data in order to drive a county-wide strategy. And what will come forward if this partnership that we've just spoken about is instigated and is effective, is an understanding and a connectivity that's not there now between policing, community safety, housing, employability and treatment. And it's only in those types of arena can we seek to have bespoke interventions and maybe a targeted police approach, because we can't treat our way out of those types of antisocial behaviour and those aspects of criminality. And equally, I would argue that the police have a set of responsibilities which are very narrow And only by having this partnership approach could we open their eyes to see that we need multi-agency approaches, and there are approaches. There's drug market mapping approaches where what you have described, you would take an area, create a problem profile, and then put together multidisciplinary teams where there is both enforcement, but also where required, but also support and treatment where required, so that we can almost stop the problem at its root cause, as opposed to operate in isolation. And those aspects, that approach is true for cuckooing, breaking county lines, which is definitely an enforcement, and then utilising treatment to pick up the pieces where individuals who are substance misusers and are vulnerable have been cuckooed, and they can have rapid access into treatment. But also those antisocial cases that you describe, where nobody really knows whose problem it is, because you don't want to criminalise somebody for taking drugs, even though they commit an absolute offence. But equally, their substance misuse isn't that problematic that they would require treatment. So we need a board of good thinkers to come up with what should we do, and what resources can we deploy appropriately to that.
Okay, thank you, Richard. Any other questions? It's gone very... yes, Pervez.
Thank you, Roy. Not necessarily a question for Richard, but I do think the board should note that the complex cocktail of drug and alcohol misuse is giving rise to significant issues across the city, and I think that is rising. What's really worrying is that younger and younger children are coming into services for these issues. And what comes across my desk in adult social care, if you ask me, well, what is it that you worry about? Is it the growing elderly population? No. Is it the increase in numbers of learning disabled people? Well, no, because we deal with that. But this area gives us huge issues and problems, and it's not just social care. It's across health, it's across police, it's across a whole range of public services, and to the point whereby we live in a health and care and welfare systems that's designed for people who engage. But unfortunately, some of these individuals don't want to engage, but they do have capacity, and it becomes a lifestyle choice for individuals or learnt and known behaviours. And we haven't got housing or care or health options for these individuals when they don't want to engage with what's on offer. And then that is a genuine, unresolvable issue. And we are finding that there are more and more of these individuals coming across our services, giving rise to huge disruption and huge cost to try and deal with their symptoms, because that's all we end up doing, because we can't deal with the causes because they don't want to. And this is a real problem, and I can see it just growing and growing, and we've really got to try and recognise that, even though this, relative to the population of the city, they're small numbers, but they consume a disproportionate amount of the system's energy, resources and time, and we've got to be more creative in how we deal with this, because it is really, really difficult.
Okay, thank you, Pervez. And it's not just people not willing to engage on drugs and alcohol. We have a lot of issues around people where we can offer support and they don't wish to engage, so the problem is still there. And I don't know whether you're going to solve that, Richard.
I think one thing I will say is I absolutely recognise what Pervez is describing, and I think what we have observed in public health is that by the time somebody is in treatment, then they are displaying symptoms more often than not of trauma-induced behaviour, and we've launched an adverse childhood experience or trauma-informed strategy which recognises that often incarceration, substance misuse and teenage pregnancy, etc., are just consequences of being subjected to 4 or more adverse childhood experiences. So I think what Pavel describes is that we need a longitudinal approach. We need to start working now with younger people to mitigate the impact of adverse childhood experiences. But there are things that you can do with older adults, I say older adults, people who are adults, to redress or mitigate some of those trauma-induced behaviours. But as you can imagine, as you get older, it becomes more entrenched and more difficult. But a lot of what we see is as a consequence of personality disorder that is driven by severe adverse childhood experience, and it's definitely something that's on our radar.
Yeah, a real challenge for the future. Okay, thank you. Any other questions? In that case, thank you very much, Richard. Really informative. I hope we'll all get copies of the slides. Yeah. If Kirsty can find a microphone. Right. The next item on the agenda is the Better Care Fund end-of-year report. So it's over to you, Kirsty, to run us through that.
Yeah, thank you. So I'm Kirsty McMillan, Director of Integration at the City Council. Hopefully quite a succinct report for you about the Better Care Fund, which, as the board will know, is a pooled budget between local authorities and NHS, primarily associated with activities that integrate service delivery for local people. The last time I came to the board in relation to the Better Care Fund was in January of this year, and at that time it was to get approval for the plan for 21-22, which felt a bit out of kilter because we're already in January, but the planning guidance was incredibly late that year. So since then, in May, all local areas had to submit a return looking at the full year, so like an outturn report for 21-22, and it wasn't possible for us to come in advance to get permission to submit that from the board, and I think a lot of local areas were in that position. So this is a retrospective report, really, so that the board can formally sign off how we did last year, and in the appendix is a summary of the actual template submission. It's pretty much all there apart from the guidance notes, which I didn't think you necessarily needed to read. So the things to note really are that in the submission we had to give a summary of what we thought were the successes and challenges as a result of the fund. Now, if you recall, the fund is really a sort of grouping of various spend activity that are delivering activities across health and care. So it's not a programme in its own right. It's really kind of reflecting a range of activities. So some of the things that are happening in the system around integration are really what we reported as successes and also challenges. So last year, I'm sure the board's familiar with the electronic shared care record that was rolled out across Joined Up Care Derbyshire. That was really successful for certainly allowing adult social care to be able to see patient level data. And that's been a long time in the coming, and there's a lot more developments to do in relation to that, but that certainly is part of the wider integration agenda, so we can have a single view of individuals who cross health and care. The other thing that we reported as a success was our local area coordination activity, which is funded by the Better Care Fund. I think as a result of the pandemic, but more so in relation to lots of different transformation activity going on, local area coordination has become more pivotal in changing the conversations that practitioners have with individuals, particularly focusing on what we describe as an asset-based approach, so looking at what individuals can do for themselves, what communities can contribute. And that is now a major strand of a wider transformation programme that's sort of building momentum across the new ICS. So that's certainly a positive. The two areas that we reported as challenges are actually very, very linked. In relation to workforce, I'm sure the board's heard from a number of reports over the months that capacity in terms of workforce shortages is just widespread across the whole health and care sector and beyond. And actually that has prevented us between us managing escalating needs in the community, but also getting people out of hospital settings quickly, because there simply haven't been enough staff to make sure that actually a timely response has been provided. We had a particularly acute period in December, January of 21 and 22 just gone, when we had that rise of Omicron. If anyone can remember that far back, people were literally just going off all the time, and that really disrupted health and care. And then the second challenge that we reported for last year, which is still ongoing, I'd say the Omicron wave pressures have probably subsided somewhat since January, but actually the home care, domiciliary care market never really recovered from that, and it had never really recovered from the end of furlough, when a lot of people who had moved into that area went back to other industries. And actually for Derby, we've always had a really successful home care market, but in the past 12 months and the first 6 months of this financial year, we are really struggling with capacity, and that is because people do not want to do the work. Providers are struggling to recruit and retain people, and the knock-on effect is that not only are people at home losing out because we can't get care quickly to them, but as people tip into a crisis, then it's also very difficult to get them back home. So that's an ongoing challenge, and certainly that was one that we reported as far as the Better Care Fund. And then on page 2 of the report, I've just put in, which is in the appendix in more detail, a summary of the performance metrics that are measured nationally. At the time of doing our submission in May, we don't actually get the specific measures. Actually, we just have to make an estimation as to where we think we are. So all of the ones that are listed here were actually forecast to be on track for the end of the year, apart from the second one in the list, which is about the length of time people spend in acute hospitals. And this is a new measure looking at the number of people who are there for 14 or 21 days or longer. And actually the data from the NHS at that time, certainly in May, was indicating that for last year, whatever the target that had been set, and that is set nationally, it's not set locally, was not on track to be delivered. In part, I think, because of some of the pressures that I've just described around the wider workforce and capacity, but overall, the demand for acute care has led, and there's a whole report you could probably have on this if you were interested, just on a higher than planned occupancy within acute hospitals. So in some ways, we just have to be realistic. The Better Care Fund contributes to that in the sense of some of the services that it funds will help people stay out of hospital and also get them home more quickly. But I think everyone's fairly realistic. This is a system issue. There's a number of factors that are driving how long people stay in hospital for. But that's certainly the area that, compared to the others, we weren't on track to meet the targets that had been set. Other than that, that was all I was going to report, really. That the appendix shows some of the other bits and bobs in the template to do with finance, so I can answer any questions on that. Otherwise, just really looking for the board to retrospectively approve the report that went in for the end of the year.
Thank you, Kirsty. Comprehensive as usual. Can I refer you to page 11 in the report? And it's just a comment in there. Number 1, it says you neither agree nor disagree, but I think that joint working has never been on such a high level across health and social care. So I would effectively disagree with the comment there, but otherwise, yes, honest.
Can I explain then? So what that was about is because the actual statement we're asked to comment on is the overall delivery of the Better Care Fund has improved joint working. So I suppose the reason that we chose neither agree nor disagree is the reality for government that the Better Care Fund is not actually driving integration at all. What is driving integration is exactly what you've said, joint working on the ground. So actually the narrative is saying there's lots of other governance that is making this happen. And if I'm honest, I think there's just a reality check that pooling funds alone doesn't make things happen. It's the relationships on the ground. So yeah, probably it was more reflective of the actual funding mechanism. It's not absolutely in no way to feel that the joint working isn't happening, because that you're absolutely right. We're collaborating more and more and more. Sometimes you don't know which organisation you work for.
Thank you, Kirsty. Any other questions? In that case, can I have approval for accepting the retrospective report? Nobody against? Okay, thank you very much.
Yes, thanks, Chair. Just very briefly, as it is just for information, I think previously brought to the board the requirement that we have to develop and publish a pharmaceutical needs assessment by the 1st of October, and I think at that point gave an overview of the process to do that through a local steering group. Then we're covering Derby and Derbyshire, just to make the Health and Wellbeing Board aware that we've progressed that as planned. The pharmaceutical needs assessment has been produced in draft form, and that's currently out to formal consultation. There's a requirement that it's consulted for 60 days, and that period ends on the 21st of August. There's a link in the report there that takes you to both the draft document and the consultation survey, and we will be kind of incorporating the feedback from that consultation into a final version of the pharmaceutical needs assessment document, and we'll be bringing that back to the next meeting of this Health and Wellbeing Board in September, with a view to requesting approval for its publication in advance of that date of 1st of October. So that's the update, Chair.
Thank you, Alison. Any questions on that? You do have the opportunity to read it at your leisure. And finally, the last one, the rules and procedures of the Health and Wellbeing Board. And I mentioned earlier about the chairmanship, and hopefully there will be a recommendation going forward to council to formally appoint me as chair for the rest of the civic year. Apart from that, Lindsay, any further comment?
Just one quick thing. I just wanted to draw the board members' attention to paragraph 4.5 to 4.8 of the report. All councillors and co-opted members of council committees are required to comply with the DCC Code of Conduct. So as part of this, the board members are required to declare disclosable pecuniary interests affecting them and their partners, and we've got to publish that information. So to comply with the Localism Act, all members of the Health and Wellbeing Board are required to complete and return a DPI form and a declaration form confirming compliance with the Code of Conduct. There are piles of documents at the back of the council chamber, so if you want to take one home and complete it and send it back to me, and I'll also send an email out probably tomorrow or in the coming weeks with email copies of it. Thank you.
Thank you, Lindsay. I hope there's going to be no objection to doing that. We as councillors always disclose any interest we have. I mean, I'm a trustee of the Liversedge Trust, which, although I don't get paid for, I have to declare that interest at council meetings, and I'm not allowed to set the fees for care homes because I'm chair of their care home committee. But it's that sort of thing. So if you're involved but you get financial benefit out of it, then it's a disclosable interest. Okay. Thank you very much. On that note, I wish you all a safe journey wherever you're going, and I look forward to seeing you at the next meeting. Thank you.